Good morning, everyone. A warm welcome to you all. And on behalf of Indian Radiologists, I would like to welcome you all to the Radiology Journal Club today. This is a slightly newer concept, and we've had two journal clubs so far. The first one was in September, which was on neuroimaging, which was taken up by Dr. Mitusha Verma. The second one was last month on breast imaging, where we had with us Dr. Shilpa Lar. I would like to thank you all for your participation, and we've received some excellent feedbacks. Also, since it's a newer concept, your feedback and suggestions are completely welcome. So do let us know if you have any ideas or anything you would like us to include in this. We've had article discussions and case discussions in the last two sessions. We would like your interactive participation as well. So do let us know if you have anything in mind. You can contact either Dr. Mitusha or me, Dr. Gauri, and we'll definitely try to incorporate those in our future programs. Before moving on, I would like to thank our co-organizing team at Indian Radiologists, Dr. Shailendra Singh, Dr. Jignesh Thakkar, Dr. Sanjeev Mani sir, Dr. Deepak Patkar sir. Their support and their encouragement is what keeps us going, and nothing of this sort would have been possible without that. So thank you so much. Also, the other members of the team, Dr. Mitusha Verma, Dr. Shilpa ma'am, who was there with us for breast imaging, Mamta ma'am, and Dr. Amit Punkar, who's always there for technical support. Obviously Dr. Ameya Kulkarni, who will be taking care of the Radiology Journal Club today in body imaging. Thank you all of y'all. So the idea behind the program is very simple. It's basically just to stay updated. We will be discussing advances and research articles, interesting cases, something new that helps you to be in touch with what's going on, newer protocols, anything that comes up new and helps you going. So this is all going to be discussed in a very interactive fashion as well. Also, all this will be streamed on YouTube, so you all can go back and go through it again if you all wish. The case articles that we discuss will be shared with you like we shared them last time. So you all can go ahead and refer to those later as well. Before moving on, I would like to thank our educational partners, Bayer, thank you, Kedar, Kanchan, everybody at Bayer for your support. It is this what keeps us going, so thank you so much. Along with Bayer, we also have Phantom Healthcare with us this year, and thank you so much once again for your continued support. Before moving on, I'm really excited to announce that we're coming up with our Sonobuzz in January. That's on 8th and 9th of Jan in Mumbai. We've had two Sonobuzz so far. This is the third event. The last one was an online event. This year, it's going to be hybrid. So we'll have an on-site as well as an online program. We have an excellent panel of national speakers for you. It's a complete fetal ultrasound program. So please go ahead and register for the same. There are some interesting concepts like the fetal face contest. So do send your entries. We'll be sharing the details in the chat box as well as on all our platforms. And do send us your paper and poster entries as well. We will share the details with you. So coming to today's program, this Radiology Journal Club will be on body imaging. We have with us Dr. Ameya Kulkarni here, who's joining us from Canada for the same. So we'll be discussing the article which is on BOSNIAK classification of cystic renal masses and a couple of cases related to the same. So it's my pleasure and honor to introduce Dr. Ameya. He's a staff radiologist at Juravinsky Hospital of Hamilton Health Sciences and an assistant professor at McMaster University. His specialty is in breast and body imaging. It's a pleasure to have you with us, Dr. Ameya. I think you can take over from here.
Thank you for those kind words, Gauri. First of all, thank you, Indian Radiologist, for allowing me to participate in today's journal club. This is something which I always kind of think every day, day in and day out when I'm reporting my CTs or MR examinations, that how to deal with certain kind of renal lesions. So without any further ado, I'm going to dive into today's sessions. A couple of housekeeping things to discuss today. There are at least a couple of slides where I will be asking you to take out your cell phones and have their cameras ready so that you can use or scan the QR code, which I'm going to show you, to access some really important websites which are recommended by the readers as well as the authors of this paper. And then this is going to be an interactive session. So there will be 2 quiz questions, which I will show you in the first session of this journal club. And the answer will be showed at the end of the presentation. So make sure that you answer those questions on the polling session. Throughout the presentation, if you have any questions, please feel free to use the Q&A feature, type your answers there. I'll be able to get back to those at the end of the session. And then as we go through it, if there's anything which you want me to do, I'll be happy to stop, go back to that slide as well. So make sure that you also pay attention to the slide numbers as I'm scrolling through them. So for example, if you have a question around, like say slide number 23 or something like that, I can always go back to that slide and we can discuss that later on. So without any further ado, let me start with the paper today. So the paper which we are going to discuss was published recently in Radiographics Journal, and it is something which is a really, really important topic which you should be paying attention to when you're reporting your CT and MR examinations. The reason why I'm talking CT and MR is, unfortunately, ultrasound fails to characterize some of the findings or some of the features which are associated with these cystic masses. We'll come to those things in the finer details of the paper. So let's look at the first polling question here. So pay attention to these 3 images, case number 1, case number 2, and case number 3. You have a sagittal CT image on the case number 1. It shows a partially exophatic lesion arising from the lower pole of the kidney. Then you have your case number 2, which is a transverse image of the kidney. I think the whole question is right on the case there. Let me try to see if I can move it around. Okay, that looks better. So case number 2 is an axial post-contrast CT of the kidney through the mid-pole region. And then the third option is case number 3, which is an axial post-contrast MR, which shows a large heterogeneous mass. So please feel free, go ahead and type in your answers. What do you think when you can apply BOSNIAK classification? Case number 1, case number 2, or case number 3? Okay, so I will keep the results to myself, but there is a little bit of a split here, but most of you are answering case number 1. And then let's go to the second polling question here. So can we restart the poll again for the second question? All right, perfect. So the second polling question is slightly different now. So I have given you 3 images. Case number 1 is a sagittal grayscale static ultrasound image of the kidney, which shows a partially exophatic cystic lesion arising from the lower pole. Then case number 2 is an axial T2 weighted image, which shows this intermediate T2 bright lesion in the mid-pole cortex of the kidney. And case number 3 is axial post-contrast T1 image, which shows a cystic mass, which shows enhancing septate. So question is that when will you use BOSNIAK 2F or higher category amongst all these 3 instances? So just type in your answers, whether you think that it's case 1, case 2, or case 3. So I guess most of you are answering it correctly already, which is good. I don't have to spend a lot of time on those things. Excellent. Okay, so now we have some little bit of an idea about what we are going to deal with today. So with this knowledge, let's go into the article. So the article which we are discussing is titled as BOSNIAK Classification of Cystic Renal Masses, version 2019, a pictorial guide to clinical use. Those are the authors who have put in lots of effort to make this a really nice pictorial guideline. And this was published in Radiographics May to June 2021 issue. These were the disclosure put forward by the authors of this paper. So now, before we go into this paper, I want to discuss some background as to what is the reason why the BOSNIAK guidelines were changed or updated to begin with. So the most important problem which starts is that what is the reported malignancy rate amongst all these BOSNIAK categories, category 1, 2, 2F, 3, and 4, if we still used the older version, which was mildly updated in 2012, especially around the CT findings. Some of the things were included in 2012. So when they went back and did an amazing systematic review in 2017, they came up with this kind of interesting discovery that the reported malignancy rates were quite variable, and they were up to 17% in BOSNIAK 2F categories. However, the biggest challenge was that BOSNIAK 3 and 4, which are supposed to be highly suspicious for malignancy, they had pretty significant rates of reported benign lesions. So which means that these patients underwent partial nephrectomy and nephrectomy to excise a lesion, which was characterized as BOSNIAK 3 or 4, but approximately 50% of BOSNIAK 3 lesions turned out to be benign, and around 10% of 4, they ended up being benign, which is not the entire purpose of why these lesions were being followed up. Now it gets a bit more interesting when you go in and check some more data. So this was data which was published in Surveillance Epidemiology and End Results database from 1975 to 2015. So the blue line here on the top is essentially the incidence of cystic RCCs. So as you see, with increasing spatial resolution of MRs and CTs, you're detecting more and more of such lesions now. But it fails to have any significant impact on patient mortality or metastatic incidence, which means that you are probably overdiagnosing or overtreating these lesions. And it further confirms this theory by putting it together what are the death rates for 10 years in patients who have T1A stage cancer. So these cancers will be less than 4 centimeter in size and mass is limited to the kidney. This death rate is only 0.2% amongst all of these treated or excised lesions. So in a nutshell, it is causing a little bit of too much harm to the patients when we are stratifying these into BOSNIAK 1, 2, 3, and 4, especially using the older BOSNIAK terminologies. And this is when they started working. The 2017 systematic review was the catalyst to change most of the things in BOSNIAK 2019 version. So let's look at the problem a little bit closer. So now, once we know what is happening, you're picking up more cystic lesions.
Okay. Right.
Sorry, I think Patkar's audio was on.
Second is coming, right?
Yes, sir.
Still not well.
Yeah, I think, sir, your audio is on.
Okay, that was fine. So now we know the problem. The problem is that we are picking up so many cystic lesions, calling them as suspicious, but most of them end up either being benign or we are treating clinically insignificant cystic RCCs. So which means that the sensitivity is very high here, but specificity is low. So in order to fix that, the new version focuses on these things to reduce the sensitivity a little bit, but increase the specificity. So you are going to be calling back or calling those lesions as 3 and 4, which are definitely going to be clinically significant RCCs. So for example, if you look at this axial post-contrast image here, there is this 5 millimeter convex protrusion within this cystic mass in the right kidney. Again, this is from the same article which we'll be discussing today. According to the older lexicon and nomenclature, this may have been classified as BOSNIAK 4, but with the new guidelines which we have in place or the new nomenclature, this will be BOSNIAK 3. So you see the difference here. The drive is to minimize calling more and more lesions as suspicious and following up more and more lesions to make sure that you are not treating clinically insignificant cystic RCCs. So the learning objectives of this paper, it focuses on 3 main things. So number 1, it is just pay attention to all the updates and rationale why this 2019 version of BOSNIAK classification was developed. So as you are aware that in 1986, the first version was kind of tabulated in terms of BOSNIAK classification. In 2012, it received a minor update, and in 2019, it was completely redesigned. And that's the one which we're going to look at today. When and how to use these various modalities and when and how to apply BOSNIAK classification is something which we're going to discuss today. So as you can see, CT-MR will always score high in terms of these BOSNIAK classification systems, whereas ultrasound may not be able to detect all the features described in the lexicon of BOSNIAK 2019. And that's why most of the times it will be limited to assessment of 1 or 2 lesions, not beyond that point, because beyond that point, you need to assess enhancement and multiple other intrinsic features which may be beyond the spatial resolution of ultrasound. Then the third and most important thing is to pay attention to lexicon. Why is it important? Because this improves inter-reader agreement. So for example, if I'm calling something as BOSNIAK 4 by going through the lexicon terminology which are designed by this classification system, the likelihood of someone else calling it as BOSNIAK 4 is also high if that person also sticks to the same lexicon terminologies. The advantage of that is it has better patient outcome because of reduced um, uh, inter-reader variability. And then, so what happened was that with the older version of BOSNIAK, they found in that systematic review from 2017 that there was a significant range or a very large range of disagreement between multiple readers. And that number ranged from 6% to 75%. And this was particularly notable in BOSNIAK 2, 2F, and 3 category masses. So 6 to 75% is a very large variation for any classification system. And it's basically, it makes a night and day difference for patient management. And then the other thing which we already discussed, that there was a large proportion of benign lesions which were being excised in BOSNIAK 3 and 4. That's the reason why this entire thing was changed. So there are multiple teaching points within this paper which were described by the authors. So number one is cystic masses are the ones which are by definition containing less than 25% of enhancing solid components. So again, you're not supposed to be measuring these things, but it's a visual assessment that the lesion should contain less than 25% of enhancing solid component, then only you can call them as cystic. Beyond this point, they fall out of the category of cystic masses. Then for category 2F or higher, we need to have at least some form of enhancement. And this is why ultrasound may not be the right modality unless you have contrast enhanced ultrasound. But again, in the current lexicon, there is no room for CEUS, but moving forward, that is something which can be incorporated. But because of this, right now, we will be focusing more on CT and MR. There is only one exception to this rule. There can be non-enhancing cystic masses which have heterogeneous bright signal on T1 weighted fat suppressed image. However, it does not enhance. Those lesions can fall under the category of 2F. But if it is homogeneous and smooth and it shows bright signal, it falls into 2 and not 2F. Then what is nodule or irregularity and how to measure it? So this is something which is really important, how to measure it, because there are so many important measurements in this lexicon that you have to make sure that you're measuring these lesions properly. So it has to be measured perpendicular to, but not including the wall or septa. So what does this mean? It means that you will be looking at a lesion's kind of septation, and then there is a bump or that convex protrusion on top of it. Exclude the septa out of measurement. That is when you will get the accurate measurement. And that's why you need very high spatial resolution CT and MR exams. Then other measurement guidelines, which are something which you should remember, that avoid using T2s for measuring these lesions because it can exaggerate the size of the lesion or thickness of septations due to debris or hemorrhagic material. Ideally, it should be done on the post-contrast sequences on CT or MR. If there are more than one BOSNIAK categories for that patient because there are multiple lesions, or maybe a single lesion has different areas which appear differently, always choose the worst category because that dictates patient management. And most importantly, do not apply these categories or these guidelines in patients who have hereditary cancer syndromes, such as von Hippel-Lindau's, Lynch syndrome, Birt-Hoff-Dubé syndromes. These are the patients who have a very, very high proportion of cystic RCCs as compared to other cystic benign lesions, is because of the increased propensity to have RCCs. So these guidelines will not apply over there. In terms of imaging techniques, so this is just a case example shared by the authors. In terms of CT, you need to have a typical unenhanced, then your nephrographic phase as well as cardiac medullary phase. It is very important to follow these guidelines to make sure that you are assessing the enhancement of the lesions correctly. I mean, obviously, you will be asked these questions in your exams. You may have a question about assessment of renal masses in your residency exams or board exams. You will have to write about all these protocols on CT and MR both. Some quick reference tools are obviously you can go to Radiology Assistant or some other websites, and you will definitely find a really nice graphic depiction of how these different phases make different things appear more obviously in the kidneys. So in this particular case, on the unenhanced phase, the authors show here that the lesion measured about 7 Hounsfield units. Then after administering contrast, there is just enhancement within the periphery of the lesion, which measures up to 32 to 34 Hounsfield units. The center is largely unenhanced, and the enhancement further increases on the subsequent nephrographic phase, and the center shows no enhancement. So this is nothing but a case where there is central necrotic component within a lesion, and this patient ended up undergoing a surgery, and this turned out to be necrotic papillary RCC, which was type 2A, and then in this 70-odd-year-old individual. So just to show you importance of multiple phases when you're performing renal mass CT. Then what is the importance of MRI? So for most of the parts, CT or MR may be interchangeable in terms of assessing these cystic renal lesions. However, there are certain areas where MR definitely excels over CT. For example, in this case, the authors show a patient with a large mass in the right kidney, which is largely calcified. So on CT, it is going to be very, very hard to assess whether that lesion is enhancing or not. And the only way to know that is that you will have to undergo a contrast enhanced MR examination, which is which has fairly low sensitivity for detecting calcium, but it has very high sensitivity detecting enhancement. So in this actual T1 post-contrast image, we definitely see that there is this thin kind of septal enhancement, which is occurring in this patient. This was essentially ultimately classified as BOSNIAK 3 mass because this was almost up to 3 millimeter size in terms of wall thickness as well as the septation thickness. So this is an area where MR comes into picture. The other would be hemorrhagic or hypertenacious lesions. Again, in those cases, MR may be used to perform subtraction imaging where the bright T1 signal is completely, it goes away and all you will see is enhancement. The authors also recommend use of this online calculator. So if you have your smartphone, you can just open the camera, scan this QR code, it will take you to this calculator. And this is based on an algorithm, which I'm going to show you later on in this paper, that you can just pick those options and you will get your BOSNIAK category for cystic renal mass, which you're assessing. So this is the QR code for this web page or a calculator. They also have an app. I never tried downloading that, but again, they also have an app which you can use on your smartphones. So now Lexicon is something which is most important in this classification because they changed the meaning as well as details and added a few more words in terms of how lesions are described. So these 4 are the most important things. Again, a beautiful graphic representation of different aspect of assessing cystic renal masses. This was initially published here in this paper. I have given a reference here below, and this was the original paper where it cited the need to change or update into BOSNIAK 2019. So what you have to look for when you start looking at a cystic mass, start with the wall first, go from periphery to the center. So if you start from the wall, again, sorry for this thing, but it's 1 millimeter here. If it becomes more thicker, it will be 2 millimeters, then 3 and 4. So you have to assess the wall thickness. Then the next thing, if it has septations, you have to assess the thickness of the septa. The 3 most important numbers here are 2, 3, and 4 millimeters. So these numbers are really, really important. Then the next category here, which you should remember, are these convex protrusions. So these protrusions can be present on the cyst wall itself, or they can be present on the septations. So when they're present on the septations and present only on one side, like in this case, all you have to measure is maximum perpendicular distance of the top of this protrusion going to the septation, but don't include septation in your measurement. And if it happens that there are these protrusions on both sides of the septa, you have to calculate a combined distance or combined perpendicular height by excluding the septa. That will give you the maximum size of those convex protrusions. The most important thing, if you look at these blue colored convex protrusions, as it is outlined by these authors, they have these nice obtuse angles with the septations as well as with the cyst wall. The next category to remember, if you look at these orange or dark kind of amber colored convex protrusions, they have acute angle with either the cyst wall or with the septation. When that happens, size of the convex protrusion does not matter, and it naturally puts it into category 4. But if it is category 3, then you have to measure the size of these convex protrusions, and we are going to come to that when we are discussing category 3 lesions. So with this in mind, the authors gave some amazing examples of different BOSNIAK category lesions. So let's go through them now. So BOSNIAK category 1. So these are essentially all benign, simple cystic lesions, which you will pick up so many times when you're doing your CT examinations. So what is the hallmark of these lesions? For example, this case here, which is shared by the authors of this paper, the wall thickness is almost around just 1 millimeter, which is something which you expect in these benign cysts. So this is a left cystic lesion, which was obviously incidentally discovered. The Hounsfield units is only 2 Hounsfield units on this incidental exam. It's kind of it's a corticomedullary phase at the time of acquisition. The arrow shows that the lesion does not show any enhancement. There are no septations, and there is no enhancement of the wall. There are no convex protrusions, and there are no septations or calcifications in the lesion. So this will be a typical BOSNIAK category 1 cyst. Now let's look at BOSNIAK category 2 cystic renal masses. So this is a bit of an interesting category and needs a lot of attention. So in this case, the authors share an actual CT examination as well as an actual MRI. Both are post-contrast imaging. So remember, you need that to make sure that whether it is a 2 or 2F, you will not be able to figure that out if you don't give contrast. So in this case, this is a 45-year-old woman, and these are actual contrast-enhanced images obtained during nephrographic phase. The lesion itself is 3 to 4 centimeter in size, and it has smooth enhancing thin wall. So remember, this is about 1 millimeter in size. The wall thickness is around 1 millimeter in size. It has at least 2 thin septations, which are shown in these MR images, and the thickness of the septation is up to 2 millimeters. There is a nodular calcification, which is shown here with this arrowhead, but the mass showed no change over a period of 5 years. They had serial follow-up data of this patient. So this cystic mass, which has thin septations, remember, thin is less than or equal to 2 millimeters, and only few septa, which is only 1 to 3, but not more than 3. These are the cysts which get classified as BOSNIAK type 2. So what are the different CT descriptors or CT findings which can be seen on BOSNIAK 2 lesions? So there are 6 different varieties or types of BOSNIAK 2 lesions described on CT. These are evaluated on cross-sectional imaging, and these are the categories. So number 1, cystic mass with up to 2 millimeter thickness and few, at least 1 to 3 septa, but not more than that. The septa and wall may enhance, and they may have calcifications of any type. But remember, they don't have convex protrusions, and the septa are not more than 3 number, and they are not more than 2 millimeter in thickness. These are the hallmarks needed for BOSNIAK 2. In terms of homogeneous hyperattenuation on CT, they can be more than 70 Hounsfield units, which essentially means that they are either hemorrhagic or hypertenacious, and they can be detected easily at non-contrast image. You don't need to do anything further in this case. However, authors describe the need to recommend an MR if the lesion itself is more than 3 centimeters, because it can have intrinsic heterogeneity, which may be easily missed on the CT because of the increased attenuation. Then category, the third variety under this category 2 lesions are homogeneous non-enhancing masses, which are more than 20 Hounsfield units at renal mass protocol, and they may have calcifications of any type. So now the problem is that you need to have a good spatial resolution to measure these cystic lesions Hounsfield units. And then homogeneous masses, which are between 9 to 20 on non-contrast CT, homogeneous masses between 21 to 30 on portal venous phase. These 2 categories, number 4 and 5, will arise when you're reporting CT examination, which is done for some other indication. For example, acute abdominal pain, rule out diverticulitis. You do a CT, and then you accidentally discovered a renal hypodense mass on a single portal venous phase, which is available to you. So now, even though the authors describe the need to describe these lesions in much detail, we should also avoid any additional imaging if you can get more data, or you can be more definitive on your imaging. So for example, if you see a hypodense renal cystic mass, which is found on a non-contrast CT, and it has between -9 to 20 Hounsfield units, you can safely call it as BOSNIAK 2. On the other side, if you see a lesion which is between 20 to 30 Hounsfield units on portal venous phase, again, you can probably call it as BOSNIAK 2 and move on. Again, you have to make sure it is homogeneous. If it is heterogeneous, you may be suspecting some internal convex protrusion. The last category is that they are homogeneous low attenuation lesion, but they are too small to characterize. So I know there is a lot of word jargon here, but some key points to remember: they should be well defined, should have smooth walls, thin, which is less than 2 millimeter wall thickness, and only 1 to 3 septa, which is again less than or equal to 2 millimeters, but not more than that. The challenge here can be seen with thick calcifications, as we discussed earlier, and that's the situation when you may need to recommend when you may need to recommend a contrast MR examination. So what is absence of enhancement? So by definition, absence of enhancement after administration of contrast is any change in CT Hounsfield units between the pre and post contrast imaging, specifically the nephrographic phase, of only less than 10 Hounsfield units. That is when you can call it as absence of enhancement. So always remember that check the Hounsfield units, put the ROS correctly, but make sure that it's not more than 10 Hounsfield units. Because if it is more than that, you'll have to call it as enhancement. Less than that, then you can just call it as absence of enhancement. Because as you're aware, there could be some intrinsic changes in CT density, even though the lesion is not enhancing. So let's look at these some important findings amongst these 6 types of CT variants of BOSNIAK 2. So as we discussed, unenhanced CT, these are 2 scenarios which you can find, especially in the situations where patient is coming in with renal colic and all you do is just an unenhanced CT. So this image shows a bright lesion in the renal cortex, a really tiny homogeneous mass, which is around 76 Hounsfield units, as shown by these authors. And the same thing here going on, a single unenhanced phase left kidney axial image, a lesion which is exophytic arising from the mid-pole, measures up to 2 Hounsfield units. Both these categories can be safely classified as BOSNIAK 2 as per these recommendations. The next variant here, which we see, is a hypodense renal mass on a portal venous phase CT, which was performed for a completely different indication, as we discussed, like for example, rule out diverticulitis, rule out appendicitis, or rule out perforation, and you accidentally see this, it falls within the permissible range of Hounsfield units to call it as a BOSNIAK 2. So always put your ROI to check how much it shows on the Hounsfield scale. The last variant, tiny hypodense lesion, again accidentally discovered but too small to characterize, again homogeneous, you can safely call it as BOSNIAK 2. Let's go to the next category, BOSNIAK 2, but on MRI. So why is it described separately? Because again, you will have slightly more spatial resolution as well as increased detail of the lesion on MR examination as opposed to CT. So it has only 3 different descriptors or categories under MRI. Let's look at one example here. So this is a CT which shows a 36 Hounsfield unit mass on this cross section of the right kidney. It does show increased enhancement from 36 to 42, but remember that 36 to 42 is not more than 10 Hounsfield units. So technically you can call it as absence of enhancement. And then this is a T1 weighted image. On this T1 weighted image, all you see is a bright homogeneous T1 signal. So this is smooth or homogeneous T1 hyperintensity on T1 fat suppressed image. This will be called as a BOSNIAK 2. If this was heterogeneous, you could have called that as BOSNIAK 2F, even if there is no enhancement in this lesion, as per the only exception available in BOSNIAK 2F category. So the most important question, which sometimes you will be asked on your cases, or you will just come across that when you're reporting, how to assess it if this lesion is hyperintensity, because sometimes it will not be as obvious as this case, that's how that happens with smaller lesions. So put your ROI into this lesion and get the pixel value at that level, and put an ROI in the adjacent renal cortex. So the difference between these intensities should be at least greater than 2.5 times. So which means that if you put an ROI here in the cortex and say it is like 3.5, if that's the number which is giving here, then on this lesion, it should be at least 2.5 times more than that. Only then you can call it as a hyperintense lesion. So now, as we discussed on BOSNIAK MR category 2, they have described only 3 variants. I'll not go into much of these details, but always make sure that we check the T2 signal by comparing it with CSF, and always check the T1 signal on fat suppressed image by checking it with an ROI placed on the renal cortex. Let's go to 2F, the category which always has a lot of challenges. And the reason why is that if you remember from some of our initial slides, that on the systematic review, which was performed in 2017 amongst the published literature, there were around 17% cancers amongst the resected BOSNIAK 2F lesions. So that's why there is a lot of heterogeneity in this class. It's a continuum of lots of benign and cystic RCC lesions. So let's look at this image, which is shared by the author. So always remember, you need to have the enhancement portion inside in place to call something as 2F, except for one thing which we already discussed. So this is an axial contrast enhanced CT image, which shows that there is a cystic lesion in the interpole of the left kidney on this transverse image. There are septations within this lesion. The septations themselves are up to 1 millimeters in thickness. And then what is happening here is that the lesion is about 3.3 centimeter, but there are many of such septations. There have to be more than 4, whereas in category 2, there were only 1 to 3. Whereas in 2F, they are more than or equal to 4, but they have to be smooth and thin. So the thickness of the septations cannot exceed 2 millimeters in BOSNIAK 2F category. Again, they have to be enhancing. In this case, the authors have data of around 7 years for this patient, so it did not change over those 7 years. But once in a while, you will have a case where you call something as 2F, and that's the whole point. You call it as 2F, and on the next follow-up examination, certain things will change in that lesion. You will see a new convex protrusion, increased thickness of septation, changes in the walls, and that is when you will have to bump up the category from 2F to either 3 or 4, depending on what you see. The next variant in this category 2F on CT is this. So now what is happening in this case, you have only one smooth septa, but that septa is minimally thickened, which means that it is 3 millimeters. So if you have one septa in the lesion, which is enhancing, and 3 millimeters in thickness, again, that can be called as BOSNIAK 2F. However, even in this patient, there was no significant interval change for 5 years. So the author have data of 5 years to show that this lesion did not change. And both of these were category 2F lesions, which showed long-term stability. So what are the features of BOSNIAK 2F? Number one, that the lesion should have a smooth but minimally thickened wall, which can be up to 3 millimeters. Then they may have enhancing wall. Again, that is something which may be expected. It can have smooth minimal thickening of one or more of the enhancing septa, or they can have many septa which can be thin. So remember, if the septa are up to 3 and they are up to 3 millimeter in thickness, it can be category 2F. But if there are more than 4 septa, then they cannot be as thick as 3 millimeters. They have to be only up to 2 millimeters. So that's something which you have to remember when you're assessing these lesions. Again, this is something which we are going to very nitty-gritty, but the reason why all of these descriptors were put into place was because of the fact that there were too many cystic lesions which were being either biopsied or resected, which did not turn out to be carcinomas. So I can see some raised hands here. So maybe let's check if I can answer the questions for the time being.
Ameya, one question in the Q&A from Dr. Akshit Bharadwaj. How to quantify the percentage of solid component?
Let me check. Okay, can you read the question, because I just see chat section here. I'm not able to see the Q&A.
How to quantify the percentage of solid component?
Right. So that's a good question. So as we discussed earlier, it is a visual assessment. So you don't have to measure anything, but visually you have to make an assessment that, okay, is this approximately 25% of the lesion or not? If it definitely feels more than that, you cannot apply BOSNIAK classification, because the odds of that lesion being a cystic RCC, or for that matter, a cystic lesion of benign potential are very, very low now. You're definitely dealing with something which is more sinister, and maybe it is going to turn out to be a malignant lesion. I think there are a couple of attendees who have raised hand, Gauri. I don't know how to get those details. Can you, I think Ibrahim was raising a hand. Maybe you can post your question in Q&A section if that's okay with you, Ibrahim. Balaram Sonane, sorry, I think it's
Yeah,
clearly.
if you have any queries, you can just post them in the either in the chat box or in the Q&A section, and we'll get to those. There's
Yes.
yeah.
Okay, so I'll wait for some questions coming up in the Q&A section, and let's keep on moving for now. But I hope that answers the question about percentage of solid component assessment. It's a visual assessment. It's not a it's not what I can say. It's not a strict guideline per se. But it's a visual assessment. You have to just do an assessment and say, okay, this is 25. So for example, like in this lesion, it is definitely not 25%. But in some of the cases which I had in the initial quiz, they were definitely greater than 25%. So let's look at the BOSNIAK category 2F MRI. This is again something which is challenging and something which you may come across because they already did an ultrasound, they did a CT, and they were still not able to sort out the problem of assessing cystic lesion, and maybe because of the fact that the lesion had hyperdense contents, and that's why they landed into trouble. So in those situations, you will see a bright lesion in the renal cortex. This is an axial T1 weighted unenhanced image. All you can see is just this bright lesion in the renal cortex, which means that it's definitely going to have some kind of hemorrhagic or hypertenacious contents. So the authors are showing this case just to show an example of category 2F MRI. So now you administer intravenous contrast. So as expected, you hardly notice any significant change here in the enhancement, but these exams are quite apart from each other. So the patient was on follow-up, and this is an examination which is performed at a later day. So the examination, so the lesion itself has enlarged in size, and on administration of contrast, it was very difficult to assess whether there's enhancement or not. So that's why you need your subtracted images to show if there is true enhancement in the lesion. So in this case, what is happening is that on this fat suppressed subtracted MR image in the nephrographic phase, you do not see any internal enhancement. So the arrow shows that the cyst does not show any internal enhancement. So this is something which is really typical of these bright T1 lesions. You definitely need the subtracted image to show if there is any enhancement or not. So this is something which is really important between category 2 and category 2F. So what are the cystic masses that are heterogeneously hyperintense on non-contrast image? So if you look at this T1, they definitely show some intrinsic changes as opposed to, let's go back to the previous case, which we saw, as opposed to this case. So look at how homogeneous this lesion appears. So this is category 2. However, in this case, which we're looking at right now, the lesion is heterogeneous on T1 weighted imaging. So that's why it will fall under the category of category 2F. Something to always remember as a corollary to this BOSNIAK category 2F, you should always assess these bright T1 lesions very carefully. Let's look at that in terms of an example which is shared by the authors here. So this was a lesion. I mean, you can ignore the heading here. I'm just explaining you why is it important to look at the enhancement. But the authors have shared a case of a patient who is a prostate cancer survivor. And on one of the follow-up examinations, they found a new hyperdense cystic lesion in one of the kidneys. So it was a right renal upper pole. So I'm just showing the authors have just shared the image which shows the lesion. So I'm not sure how the numbers are seen on your screen, but basically they were not really sure if there's equivocal enhancement or not. So they wanted to do an MRI. So on MRI, definitely you have this T1 in phase and out of phase. So all of the residents who are attending today's session, this is something which you will be asked in your examinations about T1, like in and out of phase imaging. So again, the patient underwent a full gamut of MR examination. So on that examination, it persisted. It showed bright appearance and something which is in keeping with hemorrhagic contents. The only problem was that on the non-subtracted images, this is actual T1 without and with contrast, visual assessment was quite difficult. It was really hard to separate these lesions from one another, especially to say if there is enhancement or not. However, when we put these ROIs, if you pay close attention along the posterior aspect of the lesion, you get an ROI measurement of 74, and then on post contrast, it increases to 99. So there is actually an enhancement within this lesion. So even if it is heterogeneously T1 bright on an enhanced phase, now it is showing enhancement, so which will bump it up from category 2F to category 3. So note that if no enhancing features had been identified in this case, this would have been classified as 2F. But because there are enhancing components, this will be bumped up to category 3. So always pay close attention to these lesions while you're doing your MR exams. Now let's talk about category 3 lesions. These are the ones where we start to think more about carcinomas, especially the cystic RCCs, because as you remember, we are dealing with cystic renal masses. So this is an example which is shared by the authors of a category 3 lesion, where you have this cross section of the right kidney. This is an axial acquisition post-contrast T1 fat suppressed image. All you see is a 2.1 centimeter cystic renal mass with enhancing thick 5 millimeter septa. So this is nothing but a single kind of septation here, but it is 5 millimeter. So the previous septations which we discussed about, they were all 2 and 3 millimeters in category 2, category 2F, but now this one is 5 millimeters, so more than 3. That puts it into category 3. This was at excision turned out to be a grade 2 clear renal cell carcinoma. The next example, which they have shared, it's a different patient, left renal cystic mass, axial T1 post-contrast image. Again, you can appreciate that this is subtraction, as lots of surrounding tissue is all completely, it's all subtracted. All you see here is on this portal venous phase that there is a thick enhancing wall, and this wall measures up to 7 millimeters. So again, this is BOSNIAK category 3, turned out to be a grade 2 clear cell RCC. Two more examples which are shared by the authors. So here what we see is that this is an unenhanced and enhanced image of the same patient of the left kidney, where you see a large cystic left renal mass. On excision, obviously it was grade 2 cystic clear cell RCC, but what makes it worrisome on MRI is that on this T2 weighted imaging, you see this small papillary projection or on the surface of this wall here, which measures, which kind of shows obtuse angle. So if you look at this post-contrast image, even though it is only 2 millimeters, it kind of shows these obtuse angles. That's why the patient underwent resection, and then ultimately it turned out to be an RCC. So the key point here is you will need to assess these spots in multiplanar reconstruction to exactly get a sense of what is happening with those lesions. So that was irregular wall. That's why it was excised. So let's move on to BOSNIAK type 4. Again, a case which is shared by the authors here. It shows a coronal T2 weighted image. So the white arrow shows the cystic component, and the red arrow shows the convex protrusion or nodule within this lesion here. So now this is what is happening in this patient. Then you also have another case here where you see that there is this 4 millimeter post-contrast enhancement. So again, these are category 4 lesions. Why? Because these these convex protrusions have obtuse angles with the cyst wall. So that bumps up into category 4. So again, this turned out to be a grade 2 clear cell RCC. Patient underwent partial nephrectomy. Next example here is a mass in the right kidney in the intrapolar region. Again, you see that there is a cystic mass here. However, on one of the walls, you see this large kind of solid component. It is measuring up to 6 millimeters in thickness in this patient. So this patient underwent partial nephrectomy again. It turned out to be a grade 3 clear cell RCC. So what are the key points here? You definitely see that these category 4 lesions will have enhancing nodules, and the nodules are a feature of BOSNIAK 4 cystic masses. They may have obtuse margins. The nodules may be more than or equal to 4 millimeter in size, or they can have acute margins when the nodules can be of any size. So in the first case, the nodule, irrespective of the size, it has these acute angles. So I'm really sorry if I said obtuse here, but I meant to say acute angles. So if the nodule shows any acute angles with the walls, this will be BOSNIAK category 4, irrespective of the size of that nodule. And again, make sure that you are measuring the nodules on contrast enhanced image and not on T2, because this entire thing may be comprised of the enhancing solid component, as well as some aggregates of hemorrhagic material debris, which is sitting on top of that nodule. So measure it on the post-contrast phase and not the T2 weighted image, because you may exaggerate the size of the nodule. So before we move on to the next section of this paper, the most important conclusions based on what we saw till now. Number one, further studies are still needed to assess what is the impact of changing the classification system on patient management. As you're aware, I showed you one slide where we are seeing increased number of detected RCCs, but no significant change in patient mortality as well as metastases. So we need to see how much impact we have made by introducing this new 2019 version of BOSNIAK. And the second point is what the shortcomings of previous version are addressed or not. So what were those shortcomings? Large variability in terms of agreement, lots of benign lesions excised amongst category 3 and 4. Those are some of the challenges which we faced in the previous version. So we have to check if those are improved or not. And then in the future, there should be a way to incorporate contrast enhanced ultrasound in this gamut of tests, because as you're aware, not all patients will be able to get contrast enhanced CT or MR depending on their renal function status. Then we move on to the next section of this paper, which is probably the most important again. That is a nice flow chart as to how to assess this renal mass protocol CT images and how to assign different categories to these lesions. So again, it's a very busy kind of a diagram, but you can go to this article and go through these flow chart on your own, or you can probably also just use the online calculator. It uses the same algorithm. But always remember, the areas which we want to focus on is that, number one, you need to ensure that do we have a renal mass CT protocol or not. If you don't have a renal mass CT protocol, the only areas where you can make a difference is calling certain lesions as category 1 or category 2. Anything more than that, you will need a renal mass CT protocol. Then once you have that, you have to assess for all the different categories or lexicon terminologies which we looked at, convex protrusions, obtuse margins or not, what is the thickness of the septa, how many septa, how is the wall like, are there any convex protrusions on the wall or on the septa? If they are there, how big do they measure? All of those things will help you pick one of these BOSNIAK categories. And the only other thing to remember that you may land into trouble with certain lesions and the lesions will not be classified on CT. That is when you should understand that you have to recommend an MR to these patients. The second flow chart which we are discussing in this article is about MR. Again, they have gone through a very nice algorithmic approach in terms of assessing renal masses on contrast enhanced MR examinations. So again, we have to focus if a renal mass protocol was done or not, because sometimes you may have a patient who is just coming to you for a routine follow-up of IPM, and you did not even give contrast to that patient, and then you accidentally notice a new renal lesion. So again, that's really important. But again, most important thing is if it was a renal mass protocol, that is where you have to figure out how you can classify the lesion amongst all the categories of BOSNIAK classes 1, 2, 2F, 2F, category 3 and 4. Remember that you will be making a difference in the patients who have a large chunky calcification on the cyst wall, and they are not able to tell on CT whether it's a category 2F or category 3. Those are the patients which will definitely benefit from MR, because you will be able to see if there's enhancement or not. Otherwise, you will follow all the typical features of BOSNIAK 3 and 4 to ensure that they are suspicious or not. The next important thing is that the authors also discuss use of a template for reporting. So if you're not aware of this, you can always go to RAD Report. That website has a ton of templates which you can freely download and use for reporting, or you can create your own reports. But at the end of this report, when you're assessing cystic mass, the authors recommend you can use this table as you use it in, say, TIRADS or ORADS or BIRADS, that you give a risk assessment category and what are the recommendations. And based on that, you can also recommend the same thing in your report. Remember to describe the side, size, go for the septations, enhancement, and then you have to look for convex protrusions and then describe each and every category. In terms of category-wise recommendations, obviously category 1 and 2, they don't need any specific follow-up, they are benign. Category 2F is the area where you will have to do some kind of recommendation. So the large majority of these will be benign, but when malignant, nearly all are usually indolent. So there could be a small proportion of cystic RCCs, which will be categorized as 2F. But remember, the goal is to prevent over treatment of certain amount of cystic RCCs. based on the data that we have. So generally, Bosniak 2F masses are followed by imaging at 6 months and 12 months, and then annually for a total of 5 years to assess for any morphologic change in between. So if you're doing baseline, you recommend a 6-month follow-up, and then you can recommend 12 months, and then every 1 year they can be followed up, rather than having to undergo a really invasive nephrectomy or partial nephrectomy. Then Bosniak 3 masses have an intermediate probability of being malignant. So if they have not obtained, they should consider seeking a urology consultation. They may decide whether they want to biopsy a lesion or excise it upfront if the patient has other high-risk things going on. Category 4, largest majority of these will turn out to be malignant. And if they have not already seen a urologist, they need to go and see a urologist to see if they want to undergo a surgery, what kind of surgery, and when. So now with this in mind, let's go and look at one case, which I have added here as an example, just to see how well we do in assigning Bosniak category now that we have knowledge of these different lexicon terminologies. So these are just some actual images of the right kidney in a patient who had this discovered incidentally. So we did a complete renal mass protocol. So we have an actual T2 fat suppressed, T1 pre-contrast lava. Lava is nothing but lava, vibrant, everything is just basically just Dixon imaging technique. Then we have T1 weighted water, lava, arterial phase, and then portal venous phase. So now the arrows are showing the renal mass. All we see is that the lesion is a 1.3 centimeter cystic mass without significant wall thickening and multiple more than or equal to 4 smooth thin septa less than or equal to 2 millimeters on the arterial and portal venous phase, and it has no convex protrusions. Again, the patient was just being on surveillance because this was incidentally detected at the time of previous rectal cancer resection. So we have been following this up, and it has not changed much till now for the last couple of years. So based on these categories or these descriptors, remember we have 4 or more septa, and the septa measure up to 2 millimeters in thickness. So then now what Bosniak category we can assign to this lesion? So just think in your mind whether it's category 1, 2F, 4, or category 2. So definitely we have to make sure that in this case, we assign a category 2F based on the classification parameters which we have. So this patient had category 2F lesion. Again, Bosniak category 2F lesions can be followed up at 6 months, 12 months, then annually for a total of 5 years to assess for morphologic change. This is again a quick repeat assessment of the same areas. In category 2F, you may have more than 4 septations, but they are thin. So the septa are only up to 2 millimeters in thickness, and they don't have any of the convex protrusions on them, and they will show enhancement. So again, this is probably the most important diagram in the original 2019 update paper, which was described. So obviously, you're going to recommend a follow-up. So in this patient, what ended up happening was that on follow-up, the lesion decided to change its morphology. And then 3 years later, now we start to see new enhancing nodules or convex protrusions. And some of these areas were showing obtuse angles with the cyst wall, but the height or the perpendicular height of these protrusions was greater than 4 millimeters. So now this got upgraded from Bosniak 2F to Bosniak category 4. Ultimately, it turned out to be an RCC on excision. So remember to use your category 2F judiciously. Remember that there are going to be some cancers amongst them, but the goal is to catch the cancers which will impact the patient's long-term survival, and not the ones which will be indolent, as it has been showed on multiple previous population-based studies. So now with this, let's go back. We are almost at the end of our hour. So let's go back to the quiz questions which we looked at the beginning of this session. So the first question was that when will you use Bosniak classification? So case number 1, there is definitely, you see that there's this tiny eccentric convex protrusion, which is not typically cystic. This is the sagittal view of the kidney on CT examination. So this mass is largely cystic. So just go ahead. You can go ahead and answer again. The second case here is again a case which shows a large solid component here, and again case 3 shows a large solid component. So what do you think? I'm getting very good answers here. Case number 1, most of your going for case number 1, and that's exactly what it is. So case number 1 is when you will use BOSNIAK classification because it has lesser than 25% of solid component. So excellent. Everybody has done a good job at this question. Let's go to the next question, which was the second slide. Again, when will you use BOSNIAK 2F or higher? So we have case number 1, which is a sagittal ultrasound, which shows a cystic mass in the lower pole of the kidney, axial T2-weighted imaging, which shows this high signal intensity mass in the intrapolar region of the kidney. And third one is a post-contrast image, which shows smooth and thin enhancing septations. So yeah, so most of you are answering correctly in this case. So that's really nice. So let's show you the answer. So again, as expected, case number 3. Why? Because you need a post-contrast image to assess if it is BOSNIAK category 2F or higher. So that's why first case is an ultrasound. You cannot comment if there is enhancing septations. Axial T2-weighted image, you cannot comment if there are enhancing septations or wall or any convex protrusions. And this is a post-contrast axial MR, where you can definitely comment on these septations. And in this case, as we looked at it earlier, this was a category 2F itself. So I am at the end of the presentation here. So if you have any questions about this presentation, you can always reach out to me. For now, you can type any questions in the chat section, and make sure that for those of you who have a radiographics or RSNA membership, to go on this this portion of SACME credits for this article. You can access this article for free. You can complete those credits and you can get credits, because since you spend all this time to understand the paper, there are lots of other things which are discussed in the paper. I did not go into a lot of those. I touched upon all the basics or important portions which they have discussed. So make sure that you make the use of your RSNA membership to get the credits on this article. I can stop sharing my screen and let's see if there are any questions.
Thank you, Ameya. That was really excellent. I mean, you took us through it beautifully. Really simplified the article. I'm sure they must have really loved it. There is one question from Akshat again. Sir, can you repeat the exceptions to 2F?
Good question, Akshat. Always remember that there is one exception for category 2F, and that is only when, so the general rule is that you need to see enhancement. That is when you can start calling something as category 2F. But the only time when you can call something as 2F when it is non-enhancing. And that is basically a situation when you have heterogeneous T1 hyperintense contents in a cystic renal mass, but it does not show any enhancement. So if you have a T1 bright lesion, which is homogeneous and non-enhancing, it is 2. But if you have a T1 bright lesion, it is heterogeneous and non-enhancing, category 2F. So that's the only exception for 2F where you can call something as 2F, even if it is non-enhancing. So I hope I answer, yeah, so I think, yeah, so I hope I answered that question.
Yeah, there are no more questions as such, but you can always reach out to Ameya or any of us if you have any queries, maybe later as well. Should we, I think, wait for a couple of minutes just to see if anybody wants to post something.
Yeah, sure. I'm just leaving my email address in the comments if anybody wants to get back to me later on. So you can always reach out to me.
Yeah, thank you. Do let us know your suggestions as well if you all want us to alter the format a bit, maybe include anything else. If you all want to participate, as in if you all want to discuss cases or maybe be a part of the article discussion as well, suggest some articles, we could do that as well. Also, we could alter the format in such a way where we could discuss topics or tips for writing articles, how to choose your topics, how to get things published, certain tips and tricks from our experts as well. Ameya, would you like to add on to that? There was a query where somebody had asked if we could discuss the article writing per se.
Yeah, that's a very good question. That is something which everybody struggles at. So the only important thing which I spent a lot of time in my fellowship here in Canada was, number one is, obviously you need to have, first is motivation. You need to have motivation to write something, because it is always, like, you will always find these amazing people who are writing day in and day out, and it's just rewarding to them, so they'll keep on writing. The number two is that you need to have really good collaboration, especially if you're starting early on. You need to have good collaborators, because they are the ones who are going to guide you through the process. You may not know a lot of things in terms of paper writing, like, for example, how to ensure that you are avoiding any plagiarism issues, how to avoid duplication of work. You should know the basics of statistics, because then when you reach out to your epidemiologist, you should reach out to them with some kind of solutions or answers. So at least one thing which I can definitely recommend, if somebody is starting to write their residency dissertation, let's say if you're writing your residency dissertation, and if you have questions about the methodology part, where you don't know what kind of statistical test you want to apply, there is one really good article by Radiographics. It's called as Statistics 101 for radiologists. I use it all the time because I'm completely untrained in epidemiology, so I use it all the time when I'm struggling as to, okay, how I should apply, like how I should go about the data which I have. And that also gives you idea to think about how you want to design your studies. So again, it takes very long for some research studies, which even if they're cross-sectional, they can take really long because of the data acquisition process. But once that is done, just start writing your paper, go to some real good quality research which is similar to your paper, and get some ideas as to how those authors approached the question at hand. That always helps. But yeah, I think it's an important discussion. But again, you have to start writing.
We could definitely take that up maybe in one of our future programs. We could include a discussion just on that. So thank you, Ameya, and thank you for whoever sent that query. I think right now it's just compliments for you, Ameya. No more questions coming up. Jitesh has said it's an excellent lecture, and people are thanking you. So thank you so much, Ameya. I think we can wrap it up. And thanks once again for joining us on a Sunday and for that excellent discussion. Thank you everyone who's joined in, who's tuned in on a Sunday morning for this Radiology Journal Club on body imaging. We have more such coming up in the future as well. So please do join us for the upcoming journal clubs. We will let you all know what topics and the systems that we'll be covering the next month and the one after that. So today we had body imaging with Dr. Ameya Kulkarni. I would once again like to thank our educational partners, Bayers and Phantom Healthcare for their support. And thank you to the entire organizing team at Indian Radiologists and all my team members. Ameya Kulkarni, thanks once again. And once again, I would just like to remind you all about Sonobuzz, which is in Jan on the 8th and 9th in Mumbai. It's a hybrid event. It'll be online as well as on site. So please do register for the same. Send us your paper and poster entries, and even send us your images for the fetal phase contest. So thank you for joining in. Take care and see you all next month. Bye-bye.
Yeah, thanks for the opportunity. It was really nice to talk to everyone.
Thanks, Ameya.
refurbished MRI and CT scan machines. We have achieved the highest customer satisfaction rate over the years with our highly experienced and exceptionally qualified leadership. We have become a trustworthy organization in the industry. We have one of the most reliable service and support teams in the industry. Our highly skilled technicians and service staff are present all over the India, working 24/7 to serve the best to our customers. Machines have advanced medical imaging applications like SWEN, Catagram, Enhanced 3D Delta Flow, Enhanced Inflow IR, LavaFlex, Ideal, Vibrant, Enhanced 3D Velocity, and 3D Artificial Spin Labeling. Our flagship products range from 1.5 Tesla to 3 Tesla MRI machines. Our topmost model of GE Signa 750 MRI is the most advanced application equipment for medical scanning. Various models of MRI machines are available in 8 channels and 16 channels to match suitable clinical functions. Mid-range models in 1.5 Tesla are also available to fulfill basic and low-end imaging requirements. We have successful installations all over the country with satisfied and happy clients. Our warehouse has the largest inventory of MRI parts and upgrades. Our sales and service teams work in coordination for smooth planning and executions. Our strong network of support and service staff is expanded all over India and is always ready to help and serve. Thank you all for patiently listening to us.